Okay, we'll go through another case. 54-year-old South Asian male with a family history of diabetes and heart disease, seen in follow-up after PCI last month. He had one to the RCA. He had a PCI to the LAD 2 years ago, so he's coming back. Medical history, he has hypertension, mixed hyperlipidemia. They've been treated very aggressively after his first PCI. Also has impaired fasting glucose. He's executive, a high-pressure job, travels a lot for work. He's got 3 children with many activities. His schedule makes it really hard for him to get regular exercise. And then when he's traveling, his diet is not optimal. Hey, are y'all traveling to this meeting right now? Has anybody... Was your diet been not optimal? At least the food here is pretty healthy that we're doing. 5'10", 185 pounds, BMI is 26.5, weighs 36, blood pressure 125/80. He's on Rasuva 40 and ezetimibe 10. He's on valsartan, amlodipine. He's on aspirin and ticagrelor. His LDL is 65. His triglycerides are 140. His HDL is 30. His non-HDL is 94. His fasting blood glucose is 110. A1C 6.1%. eGFR is 95. Okay, well, what do we tell him about lifestyle, LDL, non-HDL goal? What other labs would you measure in this patient? So, you know, his BMI is 26.5, PAM, his waist is 36. Is that okay?
Clearly metabolic syndrome.
So yeah, and he's South Asian, and so the issue of a 26.5, that might be pretty thin for somebody from Texas, but this particular individual. So what would you talk about his lifestyle? I mean, that's in terms of this patient. When y'all want to discuss this just for a second?
I think it's also important to note that his HDL is 30, his fasting glucose was 110. So this is a patient that is a high-risk primary prevention patient.
Secondary.
Wait a second, he's had 2 stents.
Oh, he's had 2 stents, sorry. So, but there's metabolic syndrome, and so there's a lot that you can do for metabolic syndrome, including really modifying his diet, looking at his alcohol intake, querying him about his exercise, and really improving some of these parameters. I mean, and also, I'm a big proponent of intermittent fasting based on some of my research. So there's a lot of things that you can do to improve that fasting blood sugar and some of his other parameters.
So you know, technically, he doesn't quite make, he hasn't ever had an MI. He's had a stent with it. He's not 65. He has hypertension, but he doesn't have the major event. So technically, and this is the issue of personalized treatment, but do you consider him very high risk, Pam, or do you?
So it's very tricky because, you know, major ASCVD events do not include elective stents,
Right.
which is such a weird thing. And I suppose that sort of comes in on the oculostenotic reflex. There are a lot of stents placed that are not for acute coronary syndromes or for, you know, high-risk symptomatic patients. A lot of stents just get placed randomly. So that's not a major ASCVD event. So having said that, he's had 2 of them.
He's had 2 of them.
He's had 2 of them. So in my personal opinion, I would consider him ASCVD with at very high risk. And his LDL cholesterol is not where it needs to be.
So this is the issue where sometimes maybe they don't quite make it technically, but you know, the frequent flyer to the cath lab, and as you mentioned, metabolic syndrome, family history, there's a lot going on here. So additional lab results. CRP is elevated. We heard about that today. His ApoB is 85. His LPA, which is not discordant, but it's still higher than we'd like it. And his LPA is definitely elevated. So he's got a number of things wrong here in terms of lipoproteins. And are you surprised about the CRP, Pam?
No, I mean, he has metabolic syndrome. So
yeah, you know, this is the thing is that BMI of 26.5, where is the fat? And it's going to end up being, if you were to do a, you know, CT of the abdomen, you'd see that he has increased intra-abdominal fat.
And probably fatty liver disease.
And probably has fatty liver. So, you think we need to do more for his lipids?
Absolutely.
So, absolutely. So now the question that comes up is, discussing with this, what else is going to be done. So this, we talk about the patient-physician discussion. What do you do with someone like this, Pam, and either Pam, is that he's already taking 6 medicines, okay? He's very busy, he travels a lot. So what are your options in terms of the next steps for this patient? How would you go about discussing this?
It'd be interesting to discuss with him the 2 different options for PCSK9 inhibition. Certainly, I've had nice responses. Inclisiran is approved, so a baseline, then administered at 3 months, and then just twice a year for someone like this. That certainly can be a great option, and I've had good success with it. So it's, I think this is shared decision making.
Yeah.
Agree. We have a lot of experience with inclisiran at UC San Diego, and patients really love it. Especially once they get to the every 6-month stage, very well tolerated with no side effects.
So you brought up this issue, and I think, Aaron, you mentioned adherence is being really a critical issue. So I think sometimes, and the other one, of course, when you're talking about when you move into PCSK9 with either monoclonals or inclisiran, is going to be, can they afford it? And this gets the issue of prior authorization, and then what are the co-pays for it? And so there's some differences in terms of these agents. You mentioned about administration and the healthcare. We want to point out that, for example, some of the Medicare plans, types of coverage. What has been your experience?
So what we found is for Medicare, especially because it goes through a different pathway, is usually the copays are 0. So inclisiran is very easy to get approved for the Medicare patients. The commercial payers are still a little bit more difficult. I would say with PCSK9 monoclonal antibodies, it has become a very better landscape compared to a few years ago. And Pam Morris and I, we worked on a prior authorization checklist, which is a 1-page checklist that you can get through the American Society of Preventive Cardiology website. And I just put it into my note, and I just have all the key things that the payers are looking for. It gets very easily approved.
Yeah, so it's very important to document in your note. This verbiage is simple. If you have it in there, it's going to make life a lot easier for both the patient and also for your office, because otherwise the process does. Now, question that comes up, if the insurers say that, we want you to be on this PCSK9 for the other PCSK9, what is your approach for that?
I'm happy. They're both incredibly effective.
So, fighting insurance companies when you don't need to, we have to fight them enough when you need to fight them. In general, just you go with the flow.
The only time I have to fight them is the whole latex issue, is the latex allergy issue. So that's with evolocumab. The little orange thing you pull off the end has latex in it. Whereas it does not on alirocumab. So that's the only thing I ever have to do. One thing I did want to point out for this patient, this is coming up again. Well, we've already done these, but if this patient was averse to additional pills or additional treatment, since he's already on ezetimibe, you could switch him to the combination of ezetimibe and bempedoic acid in a single pill, which would not change his drug burden at all.
Right.
It may change his copay from an ezetimibe copay, which is generic, to a branded copay with the combination preparation. He might not get enough. His LDL cholesterol 65. That may not be quite enough to make us happy. But I have been surprised that my real world lowering of LDL cholesterol with bempedoic acid is better than what the clinical trials have shown to me.
Yeah, so each people have differences. Let's just see what the audience thinks, what they would be doing here. How would you adjust lipid-lowering therapy for this patient? We can do this quickly.
So I would choose I'm going to have a metabolic moment here. He meets the criteria for getting up for primary prevention for getting, a GLP-1. So number one, I would put a CGM on him. They're very reasonably priced. And with that, if you get blood glucoses over 200, bada boom, bada bang, you got the diagnosis of type 2 diabetes, not just metabolic syndrome.
Right.
And I would be able to get him, you know, at a minimum, Trulicity, Victoza, Ozempic, for the treatment of his metabolic syndrome and to correct his glucoses. And, you know, a once a week injection is a really easy sell for people who travel. And even if they say, oh, I'm going to be gone 10 days, you can say, hey, you know, it's okay. If you're a couple days late on your injection, it's all right. The risk of hypoglycemia is incredibly low. It's very protective. And it's very easy. It's a very easy sell.
So for GLP-1, it's important. He doesn't have a diagnosis of diabetes. The A1C
He has a diagnosis of vascular disease, and we have the indication.
Yeah, so it's depending which agent you're going to use, but you may not get for something like the more popular ones right now. Where you're going to get more major weight loss, you might get refused. You might be able to get it. You need to emphasize the vascular disease, the components that he has, so therefore he merits the treatment for it. There's an issue of if you're using tirzepatide for somebody without diabetes, you may not get it.
Right. I would go with
Same thing for semaglutide.
I would go with Trulicity just because they have the indication for primary prevention. And I've
So you're kind of jumping ahead here. That was the next question. But anyway, what would you do? These are the other options for this patient. So which of these do you end up using? So we could talk about low-dose colchicine. He's had 2 stents, EPA, GLP-1 agonist, SGL2, CGMs. Do you much for motivation, Pam? Are you using much CGM or not?
I use CGM a lot in the research setting, but I'm starting to use it more clinically, especially because the price point has really decreased. And it really helps with lifestyle therapy counseling because people can see, okay, well, I'm making this bad choice and my blood glucose is spiking. So I think it helps really personalize the dietary recommendations as well.
Pam?
Actually, I have the great benefit of working side by side with my cardiometabolic endocrinology friend. We have a cardiometabolic clinic together, and he does continuous glucose monitoring for our shared patients.
Yeah, so I do think that this is certainly somebody that, even though he's busy and he's traveling a lot, the focus in here in terms of lifestyle, you know, at some point the issue ends up is, you know, you've got your profession, but you also have some children that you're raising, and you want to be around here to help them. But people have to make some tough decisions. Can he work into some exercise? Can he work on having better choices when he's eating out? And a CGM can be very helpful for motivation. A lot can be done with lifestyle here. You talked about GLP-1. EPA could be a consideration. Paul Ricker talked about colchicine. So there's a number of things that could be looked at.